Up to 80% of postmenopausal women suffer from a condition that, well, actually has a highly effective, widely available cure. But a massive number of those patients just take the medication home, use it for maybe a few days, and then literally throw it in the trash.
Yeah, it's a huge issue, and it happens all the time.
Right. So welcome to today's deep dive. We're looking at the medical mystery of genitourinary syndrome of menopause, or GSM for short. And our mission today is for you, the listener, to figure out exactly why patients abandon local estrogen, which is the gold standard treatment.
Because it really is the gold standard.
Exactly. And specifically, we want to know how specialists manage that severe medication noncompliance when the initial cure causes, well, unexpected leaks, discharge, and burning. We're working off a stack of specific clinical sources today, primarily the cervical check guidelines and a benchmark comparative study out of Isfahan, Iran. We're trying to understand the gap between a clinically proven medication and a patient's actual willingness to, put up with using it day to day.
Right, and what's fascinating here is that the failure isn't with the chemistry of the drug itself. Like, under a microscope, local estrogen works brilliantly to restore tissue.
Oh, for sure. The chemistry is totally sound.
Right. The failure actually happens in the bathroom, in the day-to-day application, when the side effects temporarily feel, well, much worse than the condition itself. We're dealing with a scenario where specialists are essentially acting as behavioral troubleshooters, trying to keep a patient on track during a highly uncomfortable transition period.
Okay, let's unpack this. Because for you listening, understanding the mechanics of these side effects really gives you a roadmap for your own healthcare. It allows you to troubleshoot these issues and advocate for yourself when a prescribed treatment feels entirely impractical. So to get into the mechanics, we have to look at what the clinical guidelines call the adjustment reaction.
Yes, the adjustment reaction, it's a huge hurdle.
Right, because we know GSM causes the vaginal mucosa to become highly atrophic. The pH shifts away from its healthy acidic state, and the tissue becomes, super fragile and thin.
Which sets the stage for a really dramatic physiological reaction when medication is first introduced. The goal of local estrogen, which is applied directly to the vaginal tissue in very small doses, is to restore cell maturation, thicken that protective epithelium, and drive the pH back down below a level of 5.
But that doesn't just happen overnight, does it?
No, not at all. The cervical check guidelines specifically highlight that during the first few weeks of application, patients frequently experience a severe burning vaginal feeling, bright pink spotting, and even abdominal pain.
Wow, burning and abdominal pain. I want to look closely at the pharmacokinetics of that burning sensation because it isn't an allergic reaction, right? Even though that is the totally logical conclusion most patients jump to.
Oh, absolutely. They immediately think, I'm allergic. I need to stop.
Right. But the sources describe the atrophic tissue as being structurally compromised. The analogy that makes the most sense here is applying a medicinal lotion to severely chapped, winter-cracked hands.
That is a perfect way to look at it.
Yeah, because it stings intensely at first. Not because the lotion is harmful or you're allergic, but because the skin barrier is completely broken, leaving the nerve endings completely exposed to the active ingredients.
And the pharmacokinetics completely support that analogy. During this initial application period, the clinical term is the loading phase. Because the vaginal epithelium is incredibly thin and the barrier is compromised, the absorption rate of the estrogen is actually at its absolute highest.
So it's like a sponge soaking it up super fast.
Exactly. The medication rushes into the tissue at a highly accelerated rate. But as the estrogen does its job, stimulating cell growth and thickening that mucosal layer, the tissue begins to heal. As the barrier restores itself, the absorption rate naturally decreases to a steady, manageable baseline, and, well, the burning sensation just stops.
Which means the stinging is paradoxically a biological signal that the tissue desperately needs the medication.
Yes, exactly.
But the communication breakdown in the doctor's office is just staggering here. If a patient is handed a prescription without a detailed explanation of that loading phase mechanism, they apply the product, experience acute burning and spotting, and immediately conclude the treatment is causing damage.
Right, because nobody warned them. The cervical check guidelines stress that advanced counseling about this specific adjustment reaction is vital. Without it, patients just walk away.
Yeah, they just throw it in the bin.
And that initial sensory discomfort is just the first hurdle. Even when a patient is fully counseled, pushes through the adjustment reaction, and heals that tissue so the burning stops, the treatment introduces a secondary mechanical problem.
And that problem is gravity.
Exactly, gravity.
Yeah.
We move from the physiological pain of the loading phase to the daily logistical nightmare of the medication literally just physically leaking out.
Let's bring in the data from the Isfahan study to quantify that exact mess factor because the numbers are pretty revealing. Conducted between 2010 and 2012, researchers in Isfahan looked at women treating atrophic vaginitis and split them into two distinct treatment groups to measure patient acceptability.
Right, and that focus on patient acceptability is crucial in clinical research.
All right, because if they won't take it, it doesn't matter how well it works. So the first group used a traditional vaginal estrogen cream, while the second group used a sustained-release estradiol tablet, specifically the brand Vagifem.
Yeah, a drug's efficacy is completely irrelevant if the delivery system causes the patient to abandon the therapy. Creams, by their very physical nature, are viscous and voluminous. Once applied internally, they melt at body temperature and succumb to gravity.
They just leak right out.
Yeah. The researchers in Isfahan tracked how this mechanical reality impacted the daily lives of the patients over a 12-week period.
And the numbers are wild. At the 2-week mark, 66% of the women using the cream reported noticeable leakage of the medication from the vagina. In sharp contrast, only 13% of the women using the sustained-release Vagifem tablet reported any leakage.
That's a massive difference.
It is. We are looking at a delivery system comparison of pouring a giant bucket of water onto dry soil versus using a targeted, slow-drip irrigation line. Both deliver water, but one creates an immediate, unmanageable flood on the surface.
That's a great visual.
Yeah.
And if we connect this to the bigger picture, the long-term data from that same study shows why the bucket method ultimately fails. By the end of the 12 weeks, an astonishing 68% of the cream users were still experiencing daily leakage.
Still, after 12 weeks.
Yes, still. Whereas the tablet group's leakage rate actually dropped to just 6%. The mechanical failure of the cream remains constant, even after the tissue has theoretically improved.
One of the most jarring metrics that Isfahan researchers used to measure this disruption was the need for sanitary towels. At 2 weeks, 44% of the cream users had to wear a sanitary towel simply to manage the discharge of the medication, compared to only 9% of the tablet users.
Which is just a huge quality of life issue.
Right. I mean, this completely undermines the psychological goal of the treatment. The objective of treating GSM is to relieve dryness, restore tissue integrity, and often, to make a woman feel comfortable in her body again, particularly regarding intimacy. Forcing a patient to wear a sanitary towel every single day to manage a viscous cream actively damages that patient's acceptability and preference.
Absolutely. Which directly causes the medication noncompliance we're talking about today.
Mm-hmm.
GSM is a chronic condition. The physiological changes of menopause do not just reverse themselves. The sources are definitive that symptoms will return if treatment is stopped.
So they have to stay on it indefinitely.
Right. Therefore, specialists must utilize long-term therapies. But long-term adherence requires the delivery system to be discreet and convenient. When a patient complains about the mess and the stained underwear from traditional creams like Ovastin or Oves, the specialist's immediate mover isn't to stop the oestrogen, it's to overhaul the delivery mechanism.
And here's where it gets really interesting. The specialist's toolkit for managing this noncompliance is vastly more nuanced than just cream versus tablet. They employ both behavioral hacks and a wide array of formulation swaps to bypass these mechanical failures.
Yeah, they have a lot of options.
The first intervention is actually entirely behavioral, right? Shifting the application time to right before sleep. By lying horizontally for 8 hours, the patient eliminates the immediate downward force of gravity, allowing whichever formulation they're using to absorb more fully before they stand up.
It's a super simple biomechanical fix, but it's often insufficient for high-volume creams. When the bedtime hack fails, specialists transition the patient to formats that inherently minimize volume. We saw the success of the Vagifem tablet in the Isfahan study.
Right, the slow drip method.
Yeah. There's also Vagirox, which operates on the same sustained release principle. These are tiny, compacted tablets inserted high into the vaginal vault, requiring very little moisture to dissolve and adhere to the mucosa, which results in minimal downward leakage.
But the sources also introduce estriol gels, like Blissel, which operate on a different pharmacokinetic principle than the estradiol tablets. Estriol is technically a weaker estrogen than estradiol, but Blissel is formulated as a fast-absorbing gel rather than a thick cream. What is the mechanical advantage of prioritizing absorption speed over a sustained release?
Well, speed minimizes the window for leakage. A fast-absorbing estriol gel rapidly penetrates the mucosal layer, By the time the patient gets up and goes about their day, the active ingredient is already integrated into the tissue, leaving very little residual vehicle to leak out.
Oh, that makes total sense.
Yeah, it provides the necessary local tissue restoration without the sustained physical presence of a melting cream or even a slowly dissolving tablet.
And for patients who find any daily or weekly insertion completely unacceptable because, having to constantly interact with a medical applicator can be its own barrier to compliance, there is a structural alternative, right? The S-string.
Yes, the S-string is really unique.
It's a soft, flexible silicone ring inserted into the upper third of the vagina. The mechanism here relies on a polymer core that releases a continuous ultra-low dose of estradiol over a 90-day period. It bypasses daily applications, messy creams, and applicators entirely. But looking at this critically, swapping formulations introduces entirely new logistical problems for the patient to navigate.
It really does. Every delivery system carries a trade-off, which is why specialists must customize the approach for each individual.
Let's look at those trade-offs. The Vagifem tablets require a single-use plastic applicator for every single insertion. For a patient on long-term, twice-weekly therapy, the sheer volume of daily plastic waste is a significant environmental and lifestyle annoyance.
Right. Patients get really frustrated by the waste.
And conversely, the S-string ring, while solving the daily application problem, is a physical object residing in the vaginal canal for 3 months. That fundamentally changes the mechanics of intercourse and internal comfort.
Exactly. Specialists navigate those exact concerns by fine-tuning the prescription. If a patient rejects Vagifem due to plastic waste, a specialist can pivot to Vagrex, which provides a single reusable applicator for the entire treatment cycle.
So that's a great swap.
Yeah, and if even a reusable applicator is undesirable, the specialist might utilize Invagia.
Oh, right. The sources note Invagis is an estrial pessary with no applicator whatsoever. It's designed to be inserted purely with the fingers.
Yes, which eliminates the applicator waste entirely. However, the mechanical trade-off with Invagis is its formulation base.
Yeah.
It utilizes a specific waxy base to hold the estriol. Biochemically, that wax interacts with and degrades latex.
Oh, wow. So you can't use it with condoms.
Right. Therefore, while solving the waste issue, Invagis introduces a new barrier for patients relying on latex condoms for contraception or STI protection. The clinical strategy is just this constant negotiation between the pharmacokinetic delivery of the hormone and the lifestyle reality of the patient.
Let's assume the specialist successfully navigates this negotiation. They've counseled the patient through the burning of the loading phase, swapped the messy cream for a fast-absorbing gel or a targeted tablet, and resolved the environmental or intimacy concerns. The physical barriers are eliminated, yet patients still abandon the treatment due to a massive psychological barrier.
Yeah, the fear of long-term hormone exposure.
Exactly. The box itself becomes the barrier to compliance.
This is perhaps the most difficult hurdle, because it involves overcoming regulatory messaging. The warning pamphlets included in local vaginal estrogen packaging are often identical to the boxed warnings mandated for systemic oral hormone replacement therapy.
Which is terrifying to read.
Absolutely.
Yeah.
Patients open a localized treatment designed strictly for vaginal atrophy and are suddenly confronted with warnings about breast cancer, cardiovascular disease, and endometrial hyperplasia.
But when you look at the pharmacokinetics outlined in our sources, those warnings are deeply misleading for this specific application. Specialists actually have to actively deprogram the fear caused by the manufacturer's own insert. They do this by walking the patient through the actual math of systemic absorption.
And the math is incredibly reassuring.
Right. Because the sources show that using a standard 10 microgram vaginal pessary twice a week for an entire year exposes the body to the exact same amount of estrogen as a single 1 milligram oral HRT tablet, a whole year versus one pill.
That pharmacokinetic reality completely changes the risk profile. The systemic absorption of local vaginal estrogen is clinically negligible. The medication remains localized in the target tissue. Because the hormone is not circulating through the bloodstream at high levels, the risks associated with systemic HRT just do not apply.
This localized mechanism also eliminates the need for complex hormonal balancing, right? With systemic HRT, a patient with an intact uterus must take a progestogen to prevent the estrogen from thickening the uterine lining, which carries an endometrial cancer risk.
Correct.
But the clinical guidelines emphasize that because local vaginal estrogen does not reach the uterus in meaningful quantities, endometrial protection is entirely unnecessary. Current evidence demonstrates absolutely no association between this local ultra-low-dose treatment and new malignancies or cardiovascular events.
And we see the safety of this localized mechanism, highlighted by how it's prescribed in tandem with systemic therapy. Up to 25% of women utilizing systemic HRT patches or pills still experience localized vaginal and urinary symptoms because the systemic dose isn't sufficient to reach those specific tissues.
So they double up.
Yeah, specialists frequently prescribe local estrogen alongside systemic HRT without compounding the systemic risk.
Yet, for patients who are strictly advised against any hormonal interventions, such as those on specific aromatase inhibitors for estrogen receptor-positive breast cancers, specialists integrate non-hormonal tools to achieve tissue health. The sources highlight vaginal moisturizers like Yes, Silk, or Replens, and we need to differentiate these from standard intimacy lubricants because their mechanism of action is entirely different.
Right, standard lubricants really just provide temporary friction reduction. Vaginal moisturizers, however, are formulated with bioadhesive polymers. On a molecular level, these polymers physically bind to the epithelial cells of the vaginal wall.
So they actually stick there and hold on to the water.
Exactly. They trap and retain water at the cellular level over a period of days, mimicking the natural moisture matrix of healthy tissue, while simultaneously containing buffers that help lower the localized pH.
But the sources contain a critical mechanical warning for patients attempting to combine these treatments. If a patient is prescribed local estrogen pessaries, but also utilizes these bioadhesive non-hormonal moisturizers for extra comfort, they must carefully separate the application times.
This is a huge point of failure if they aren't told.
Yeah, because if you insert a targeted hormone tablet while a thick bioadhesive polymer is actively coating the vaginal wall, that polymer acts as a physical barrier. It prevents the estrogen from dispersing, dissolving, and absorbing into the underlying tissue. The moisturizer effectively blocks the medication entirely.
And this raises an important question regarding the totality of how specialists manage this condition. True medical compliance isn't achieved by just handing over a biologically effective pill. It requires teaching the patient how to sequence their bioadhesives, how to navigate applicator waste, and how to understand their own absorption rates.
It's a whole education process.
It really is. When a specialist successfully guides a patient past the loading phase burning, the mechanical leaks, and the regulatory fear-mongering, the clinical response is incredibly reliable. Tissue elasticity returns, urinary symptoms decrease, and quality of life is restored.
So what does this all mean for you? It means that experiencing side effects like intense stinging or unmanageable discharge does not mean the medication is failing or that you are fundamentally incompatible with the cure. The medical literature proves that genitourinary syndrome of menopause is manageable, provided you have the right delivery system.
Exactly. You just have to find the right fit.
Right. When your doctor hands you a box with a severe warning label, you can confidently point to the pharmacokinetic data proving the ultra-low systemic absorption. You have the knowledge to ask for a fast-absorbing estriol gel instead of a melting cream, or, a reusable applicator to fit your environmental priorities.
As we conclude, there is one final, highly specific pharmacokinetic detail from the clinical literature that adds an entirely different dimension to medication compliance.
Oh, this is fascinating. Please share this.
Well, while the systemic absorption for the patient using local estrogen is negligible, there is a documented interpersonal factor. Clinical evidence demonstrates that if a woman applies local vaginal estrogen and engages in intercourse shortly before the medication is fully moved out of the vaginal vault and into the cellular tissue, there can be a measurable increase in the serum estradiol levels of her male partner.
Wow. So the active ingredient transfers through direct mucosal contact before the loading phase is complete.
Precisely. The partner physically absorbs the unintegrated hormone. To mitigate this, specialists explicitly advise patients to separate application and intimacy by several hours. If we connect this back to the core issue of why women abandon this treatment, we have to consider the behavioral burden this places on a relationship.
Oh, completely. Having to calculate medication absorption times before initiating intimacy completely alters the spontaneity of a partnership. Navigating the mechanical reality of explaining that contact must be delayed to prevent cross-absorption introduces a totally hidden psychological hurdle.
Yeah, it's a very awkward conversation to have.
It adds a whole layer of relationship management to a medical routine that is already fraught with physical discomfort and logistical mess.
It perfectly illustrates why diagnostic and treatment landscapes are rarely straightforward. The most effective clinical solution often creates a cascade of secondary behavioral challenges that the patient must, silently manage at home.
Understanding the biological and mechanical why behind the burning, the leaking, and the timing is the exact tool you need to find a formulation that actually integrates into your life. Thank you for joining us on this deep dive. Keep examining the science behind the side effects, understand the mechanics of your options, and never settle for a treatment that forces you to compromise your daily routine.